All right, everyone, thank you for coming to another trauma conference. Today we have Rami Aref, one of our second year trauma surgery fellows, here to talk about abdominal disasters. I'll keep it short, and Rami, it's all yours.
All right, good afternoon, everybody. Thank you for joining me. So kind of why I decided to talk about this, because I think nowadays we're seeing more and more utilization of patients who end up with open abdomens after massive traumas, and I really wanted to take a look at the data and the indications that would truly justify these. And so that's how I came up with this topic of the role of damage control and judicious resuscitation. I have no disclosures. So this quote by Harvey Cushing is quite interesting, and one that I find very applicable. And what he says is that he wants to see the day when someone who's appointed a surgeon where he had no hands or she had no hands, because the operative part is kind of the least part of the work. So when we talk about damage control operations in the surgical history books, they were first sort of performed in the early 1900s. I think Halstead kind of was described as doing one in 1915, but really the modern day definition of a damage control operation came about in the 1990s, and it was a true pivot from prior surgical practices, and it sort of came about with this identification of the lethal triad that we all have heard about quite significantly. And this never-ending cycle where a patient comes in who's bleeding and becomes acidotic, and they subsequently have become hypothermic, and that leads to decreased coagulation with blood clotting. And that is a never-ending cycle that's kind of associated with the trauma triad of death. And what they identified in these earlier operations, specifically in the studies in the early 90s, was that in these patients, that if you were able to perform became lovingly termed a damage control operation, you had a higher success rate of improving patient outcomes and potentially saving people's lives. And the definition of this kind of consists of three phases. There is control of bleeding and contamination, there is the ICU resuscitation component, and then there is the subsequent definitive repair. When you look at some of the physiology, specifically in regards to calcium, Mignotti et al. Sort of noted that there was a significant amount of hypocalcemia on arrival of patients to the emergency department. This was then followed by Giancarelli, who noted that patients who had a higher mortality if they had an ionized calcium of around 0.9. They proposed subsequent to this that this is now a lethal diamond, so to speak, where hypocalcemia is actually one of those circuitous components that's associated with the lethal triad. And so the new proposed, sort of metric is the lethal diamond, where, coagulopathy becomes an issue because you need calcium, but they're hypocalcemic because they're losing blood, and then we transfuse them with massive amounts of blood, which subsequently exacerbates hypocalcemia. This also potentiates acidosis and the subsequent hypothermia that's associated with, decrease in liver metabolism, and the fact that, citrate and blood products makes the patients more hypocalcemic. And so, this then begs the question of, what is the standard day definition of damage control, or what is the criteria for damage control? And, if you look through all of the guidelines, a sort of consistency, so to speak. I mean, the numbers vary slightly based off your resources, but generally speaking, a patient who's hypothermic with a temperature of less than 35, a pH of less than 7.2, a systolic blood pressure of less than 80, and a requirement of blood transfusions of greater than 10 units, or an EBL of around 4 liters, and an OR fluid replacement of about 10 liters. They also sort of combine this with associated life-threatening injuries in a second anatomical location, or vascular injuries in an inaccessible location. Hello? Hello?
Rami, basically every single backline is in here.
I think there's someone not muted, so I'll make sure they are.
Okay, no worries. And so, this all sort of combines these patients who then subsequently will have some sort of a clinical evidence of a coagulopathy or an inability to close the abdomen. Now, the modern day damage control laparotomy, sort of the way we would describe this, initially you'd go in, you'd pack all 4 quadrants. We've sort of identified that, while that is very nice to be sort of regimented in that, some of the newer stuff we look at is finding that having a more effective way to control bleeding would be with very specific targeted packing. And this kind of allows for sort of meaningful compression along a specific vector as opposed to just arbitrarily packing in all 4 quadrants. Your secondary goal then is to, of course, control contamination. If it's a hollow viscous injury, should you just control it with clamps or a temporary suture? And then your third goal would be to sort of elucidate whether or not this qualifies as a damage control operation. Is the patient hemodynamically stable? Is the patient coagulopathic? Are there external factors that, come into play with this? Are you the only trauma surgeon, the only trauma team, and you have 3 more gunshot wounds coming in? All of those sort of play a role of sorts in terms of determining whether or not a patient warrants a definitive repair or a damage control operation. Once you sort of finish that component, the ICU management is, absolutely crucial. You are correcting the lethal dive, and you are, adjusting their core temperatures. You're fixing their coagulopathy. The proper trial looked at, appropriate 1-to-1-to-1 transfusions and sort of guiding your subsequent resuscitation with, current technologies like TEGs or ROTEMs. An interesting article by Aref in 1993 sort of demonstrated that if you clear the lactate within 24 hours, that's associated with 100% survival. And then, sort of on the back burner of all of this, while you're trying to, adjust the patient's physiology after going to a major traumatic incident, is sort of balancing this resuscitation with the risk of abdominal compartment syndrome and your inability to subsequently close them. So this leads us to kind of the penultimate question of ICU management that, if any of us here can answer, I think none of us will ever have to work a day in our lives, but, what is a patient's fluid status? And I think one of the things to sort of be cognizant of is that there are fairly significant fluid shifts that occur in these trauma patients, right? You have shock related to a significant amount of hemorrhage in these patients. And while we're adequately transfusing them in the OR in conjunction with, controlling the bleeding and, giving them blood with our anesthesia teams, this subsequently leads to kind of shunting from the GI tract, right? This will lead to sort of a perhaps transient component of intestinal hypoperfusion, right? You then are sort of exacerbating all of this by, mechanically packing, and then the subsequent reperfusion associated with fixing whatever, hemorrhagic insult there was. And then, the sort of added impact of restoring their sort of normal circulating volume and that, ischemic reperfusion injury that's kind of associated with that, and the release of all of the inflammatory cytokines. And so that will subsequently lead for you to having, significantly edematous bowels and significantly edematous organs that, sort of add to the challenge of potentially closing these patients' abdomens. So, when we talk about assessing volume status, there really isn't a gold standard. There are multiple modalities available that I'm sure everyone here is very familiar with. And really, there's no good way to sort of assess this other than kind of a combination of clinical gestalt and kind of using whatever clinical modalities and objective modalities that you sort of deem fit to sort of assess a patient's volume status. So the next sort of thing to sort of address in this, is kind of what are our adjuncts to fascial closures? So in 2022, in kind of September, so a few months ago, the Eastern Association for Surgery of Trauma did a meta-analysis that evaluated the practice management of an open abdomen. And the things that they were really looking at are some of the things that are now extremely hot topics in the world of trauma surgery, right? Do you diurese these patients? Do you give them hypertonic saline? Do you perform direct perineal resuscitation? And they evaluated kind of the best literature available for all of these. And they sort of took kind of sample articles that sort of demonstrated the best available research they could identify. And they performed kind of qualitative and quantitative analyses on these. And what they found was that there's really a true inability to grade the evidence, right? All of the study designs are very small sample sizes. There's significant variability in these study designs. And the two main outcomes that most of these studies sort of looked at were primary closure and mortality. And so what East basically said was that they really can't make any recommendations on what is the best way to sort of manage patients with an open abdomen in the ICU subsequent to their traumatic operation. And so kind of to go over the studies that they looked at, the first one was by Webb et al., published in 2012 in the Journal of Emergency Trauma and Shock. And this was kind of a retrospective evaluation of patients from 2004 to 2008. And their sort of primary outcomes were primary fascial closure and primary fascial closure within 7 days. And they had some secondary outcomes, including length of stay and ventilator days. The patients had similar demographics, but when you read their paper, they actually had a very poor selection criteria that was described. It's really hard to tell how they determined which patients received Lasix and which patients did not receive Lasix. And as you can see, there's quite a significance in the cohort, right? There's only 25 patients who, received Lasix diuresis the entire time versus around 114 patients who did not receive any Lasix diuresis, right? What they sort of found in their paper, and it's hard to make any sort of judgment on this, is that the Lasix patients kind of had more open abdomen days and longer lengths of stay. The other thing that was sort of interesting about this, especially if you're sort of commenting on the utility of using something like a Lasix strip to improve, primary fascial closure, is that they didn't necessarily document volume status in any way, shape, or form in their paperwork, and they didn't necessarily demonstrate the data for that. So it's really hard to come to any sort of conclusion as to whether or not these patients actually did benefit or did not benefit. And so what they said at the end of it was that it didn't demonstrate an increased rate. But for the reasons that I sort of suggested above, it's really hard to take that data with anything other more than a pretty big grain of salt. A study by Tien et al. Then looked at patients. It was a preliminary prospective study. And what they did was they looked at open abdomens who had vacuum closure or mesh-mediated fascial traction. And they looked at a total of 27 patients. And 16 of those patients received albumin with torsemide, and the other 11 patients were their control patients. And these were fairly non-randomized group assignments. When you sort of look at these patients and how they were selected, the patients were sort of decided by the patient's proxy or by the patient themselves. Not sure how they did that in an intubated ICU patient, but realistically, there was not actually a randomization prospect. They did actually track patient weight to sort of demonstrate that these patients, did lose weight or didn't lose weight. And they did demonstrate a higher early closure rates in patients who received diuresis. Now, it's hard to interpret this data for anything else that it is. It's a very small sample size. There was non-randomization associated with it. The other thing that's sort of interesting here and not very well mentioned unless you kind of read through the finer font of this paper is that the diuresis was also done in conjunction with kind of direct peritoneal resuscitation, which, would kind of throw off all of your data in this set because that sort of works through a very, very different physiology. And so again, another, data point for something that we're sort of using that might have benefit that unfortunately the study wasn't that great to sort of look at that. Now, in 2013, the title of this article is published in the Journal of Trauma and Acute Care Surgery was Chasing 100% and how the use of hypertonic saline to improve early primary fascial closure. This was a retrospective study of trauma patients underwent damage control laparotomies. They had about 23 patients who received 3% saline. The 54 patients received isotonic fluids. Their median fluids in the first 24 hours were lower in the hypertonic saline group. Their time to fascial closure was shorter in the hypertonic saline group. And that they documented at the end of it that their primary outcome of early primary fascial closure was 100% versus 70% in isotonic patients. Now, again, this was a retrospective study. It had no protocolization in terms of how patients were chosen. And it was a very limited study in that. To make the commentary that patients, received less fluid in the first 24 hours in the hypertonic saline group is kind of a fair stretch, right? If you actually look at how the fluid was administered, it was actually a non-equivalent fluid administration in both groups. And kind of the last most important thing, kind of given the power of their study, while it was perhaps a 100% early primary fascial closure rate, this was not statistically significant as was demonstrated in their data. Now, This next article we're going to talk about right now, and we're going to talk about it a little bit later in the talk in a little bit more detail. This was a study that looked at, the impact of standard protocol implementation for surgical damage control. And this was a retrospective cohort analysis of about 138 patients after a damage control laparotomy. These were 60 patients who had hypertonic saline and 78 patients with LR. The patients who received hypertonic saline received it at 3% for about 30 cc's an hour. At 48 hours, these patients had received lower IV fluid resuscitation and higher serum osmolalities, and they sort of demonstrated that they had a statistical significance of higher primary fascial closure compared to the protocol group. Now, the issue with this specific study is that they had very, very, very strict exclusion criteria. So if you had any semblance of kidney disease, or if you had anything else that kind of was a pretty significant medical comorbidity, you were sort of removed. This was all performed against kind of a matched historical cohort. And this was a protocolized design in that all of these patients underwent a very, very, very strict protocol that we'll discuss in more detail later. It's hard to sort of take those two studies that talk about hypertonic saline and say, you can give a recommendation to give or not to give these, right? The two studies are extremely different. One's a protocolized design with more patients. The other one's a very small sample size. They seem to suggest that there might be some benefit with it. The physiology makes some sense, but it requires kind of a slightly more in-depth evaluation of whether or not there is true utility in using hypertonic saline. Now, these next three studies are all by the same group of Smith et al. They are all published in the Journal of the American College of Surgeons, and they're sort of a progression of their data over a span of about 10 years. And the first one was published in 2010. And in this paper, it was, a retrospective case match study of patients who had damage control laparotomy. And so what they did was they took 60 patients, 20 of them were in the study and 40 were matched cohorts. In the study patients, these patients received direct peritoneal resuscitation compared to their 40 historical matched cohorts who had kind of their standard protocol, so to speak. In the DPR group, they found that they had about a 4.35 day to closure plus or minus 1.6 days, whereas the standard was 7.05 plus or minus 3 days. I mean, if you look at that sort of just from a global perspective, kind of a 5-day decrease in generalized time to fascial closure is a fairly clinically significant, at least, decrease in primary fascial closure. And so that's what they concluded. They said that, it shortened the interval to definitive fascial closure. And so just to kind of go over what direct peritoneal resuscitation is, essentially you're putting a trauma backpack on the patient connected to a Y connector and suction. And you essentially have, two JP drains or, larger bore tubes kind of sitting in both of the patient's kind of retrocolic areas, and where you're instilling a peritoneal dialysate solution of some sort. And the theory behind this, and kind of a lot of it came out of the University of Louisville, if I remember correctly. And a lot of their data sort of looked at how you can sort of adjust the intra-abdominal physiology to create kind of a hyperosmolar environment and decrease that, bowel wall edema and decrease that sort of visceral edema that you get after the massive resuscitations, and sort of improve the ability to close abdomens kind of more efficiently. Now, the second study is by that same group in 2014. And, here they were looking at, treating abdominal catastrophes and sepsis with direct peritoneal resuscitation. And this was a prospective study that evaluated damage control laparotomies and direct peritoneal resuscitation in patients who had intra-abdominal sepsis. These were 88 patients over a 5-year period. They were propensity matched. They used 2.5% deflex, and these are all matched using Apache 2 variables. And what they showed was that definitive fascial closure was about 68% versus 43% in kind of the standard group. And their time to closure was again shorter, and their 30-day mortality was lower. And what they concluded was that this led to a reduced time to definitive abdominal closure, and it reduced their complications with a relative risk of about 0.57%. Now, this is a third trial in 2017 by the same sort of group. This was, again, a prospective study from 2011 to 2015. And they had 103 patients enrolled. They randomized them. These were 52 patients who got direct peritoneal resuscitation and 51 who received a standard resuscitation. These were a matched patient cohort, and their method of closure was kind of standardized across the board. And again, they sort of demonstrated very similar data points, right? That the time to definitive closure was shorter, that these patients did receive sort of equivalent resuscitation when you look at how much blood products they received, and that their primary fascial closure rates were higher, and they had lower intra-abdominal complications. Their 30-day mortality was lower. So all of this sort of suggests improved outcomes. And I suppose the issue that I have with these three studies, and not that they're not necessarily good studies, but is that these are all sort of looking at the same patient population. And it's a lot of these patients were sort of triple enrolled in all of these studies kind of over time. And so it's hard to truly interpret the data. Is there a true difference? And one could argue that yes, if all these patients are undergoing a true standardized method of approach of managing these patients and everything was sort of standardized across the board, that data could be significant. But I think it sort of leads to a lot of confusion when you evaluate these data points and kind of notice that all of the similar patients were sort of reviewed in all these similar studies over time. And so this sort of then kind of leads us into our, the big question that we have, right? And it really is that, in these patients who are undergoing these massive trauma laparotomies, who are actually, really sick, do we close them or do we not close them? And I think this kind of begs a very interesting question, especially when you start to take a look at the data that's kind of been surrounding this. So this is a study from 2000 to 2003 out of shock trauma, and this was a prospective study. And what they essentially did is that they wanted to evaluate the long-term impact of damage control laparotomies. And so they took 88 trauma patients after a damage control laparotomy. Of those patients, 63 patients survived their initial hospitalization. And these patients were followed up for about roughly 5 to 7 years afterwards. They kept following until about 2008. And what they concluded was that, damage control laparotomy is an effective way of managing these very injured trauma, while accepting the fact that they come with a substantial complication and readmission rate. And so, when you look at the articles that I've sort of reviewed, if you remember earlier on, we said that kind of modern damage control sort of came out in the early 90s. And one of the first studies that sort of looked at that was Rotondo et al. And in Rotondo et al, what they sort of found was that their survival was roughly 58%. In 2001, sort of with the advent of improved resuscitation, Johnson et al. Found like about a 90%. And in this study, they found that their survival was about 72% using a damage control laparotomy technique. And so then when you sort of compare the demographics of these patients, right, they're split about 50-50 in terms of penetrating versus blunt injury, and about 90% of the penetrating injury survived relative to the 54% of the blunt injury, which sort of, in general kind of fits with general understanding that, blunt trauma patients tend to be more injured perhaps than a penetrating injury. They then took that data and sort of stratified it and followed it out over, their readmission rates over the 8 years that they followed them. And every single patient that survived was readmitted at least once. And multiple patients were readmitted kind of multiple times over. If you look, many of them had multiple ventral hernias. Some of them had, some ortho issues that they had to come back for. There were a couple of fistulas that required, multiple admissions. I mean, even on the 7th admission, about, several years out, their average length of stay was still 12 days. And while yes, a lot of these patients did survive, their subsequent medical comorbidities, their subsequent readmissions over time, as you look at these patients, the generalized perhaps burden both on themselves and on their healthcare system is quite significant and not necessarily to be scoffed at. So this study then looked at, it came out in 2017, the Journal of Trauma and Acute Care Surgery, and it followed the mortality following an emergent trauma laparotomy. And this was a multi-center retrospective study. So if you look at this was a retrospective study, and it looked at the rate of mortality from 2012 to 2013 across 12 level 1 trauma centers in the United States. And, patients who came in with a systolic blood pressure of less than 90, a significant amount of deaths happened within the first day. After that, if you came in and you were not hypotensive, your mortality sort of improved. When you look at it by institution, their percent of mortality is anywhere from 20 to 40% based off of the 12 different institutions across all these patients. And the patients who are hypotensive less than 90, their mortality sort of was significantly higher. When you then sort of look at how they stratified these patients, again, you'll see that all patients from their total N, their death was about 21%, but their time to death kind of varied relative to all of the other sort of caveats. And in patients who were significantly injured, right, the patients who, if you abide by the original criteria with which patients should receive a damage control laparotomy, their deaths are around 46%, despite heroic measures. So this article came out in the World of Journal of Emergency Surgery, and it was published in 2021, I believe. And it sort of looked at, what really is the evidence for the use of a damage control surgery and damage control interventions in civilian trauma patients. This was a systematic review. And they wanted to find, which of any of the indications that we perhaps can sometimes use to justify a damage control operation were valid. It was a meta-analysis. They evaluated a total of 39 studies, 36 of which were cohort studies and 3 of which were cross-sectional studies. And I came up with 59 sort of unique indications rather. Of those, really only 10 of them met like content validity, of which, they felt that, based off their statistical analysis of the data, that, the content within those studies sort of really demonstrated an actual indication, and 6 of which met, standard criteria and validity. And so when you sort of look at this data, they sort of give you a key kind of on the right-hand side there. Really, there's only one that has true strong evidence that would predict sort of reduced survival, and as a possible indication that has true significant data to support it, and that was unstable patients with combined abdominal vascular or pancreas gunshot injuries. Like, those were the patients that, after they reviewed all of these articles, that they found were the ones that had true validity. A couple of the injury patterns had, moderate evidence, and whether that's, hypothermia or, their ISS score. And then, in some of the cohort studies, they sort of identified that right upper quadrant injuries with associated hypotension may have some moderate evidence. But the remainder of the, indications that they could find, they really couldn't find any true data to support the utilization of a damage control laparotomy. And again, this is sort of, a continuation of that same sort of data point, was that, in these patients, again, the only statistical, significant evidence that they found was that if patients received transfusions of greater than 10 units, or had an injury score of above 25, or were hypothermic less than 34, was there a true indication for a damage control operation. And, that's sort of demonstrated a few times in the data points here. And it just goes further to question that, a lot of these studies were evaluating damage control laparotomies with a variety of different indications, but that really the only true indications are the ones with this strong evidence to support it. So what they concluded was that really there are only a few indications, and they recommend, really, and this is quotes from their article, that it should be used with respect for the uncertainty regarding its effectiveness, and only to be used when definitive surgery cannot be entertained. There are limitations to this because it was limited really to torso trauma. Another real limitation is that, a lot of the lab values this was a retrospective retrospective meta-analysis. And so a lot of the lab values that were perhaps demonstrated in these studies were really static lab values or data. I think it also fails to comment on the fact that sometimes the decision-making process is multifactorial, and it's not truly simply always based off of the physiology of a patient. Another thing to consider is that a lot of the data in these meta-analyses were from like 1983 to 2017. And, there is a pretty significant argument that, especially with the advent of using whole blood resuscitation and some of the newer resuscitation techniques that we have, that a lot of those newer techniques may have prevented the physiologic need for DCS, which may have even potentially skewed the, their, so to speak, true indications for a damage control laparotomy. So this article comes out of the University of Houston, and a few of these articles actually come from the University of Houston. And this was published in 2019 in the Journal of Trauma and Acute Care Surgery. And this was it was a Bayesian analysis and a propensity matched scoring evaluation of the effect of damage control laparotomies. And so, in their preamble of their talk, they talk about how it was initially described for a narrow inclusion criteria, but that when you look kind of globally, so to speak, at trauma centers across the United States, that inclusion criteria is now approaching 30 to 36%. And what they wanted to know was that, was basically to determine what the effect of this was on major abdominal complications and the subsequent resource utilization. And they think a lot of this, sort of confusion really stems to patients with whom surgical equipoise exists, right? This is not, these data points in these discussions are not necessarily looking at the patient who is overtly hypotensive, overtly hypothermic, overtly coagulopathic, who truly is in that lethal diamond. This is for the patients who they might be on a little bit of pressors, they've gotten some volume resuscitation, what is the right surgical answer to exist? And, ultimately it comes down to a combination of surgeon decision along with a conversation with their anesthesia colleagues and, sometimes what else is going on in the hospital and sometimes what truly is best for the patient. And this was kind of a retrospective analysis over a calendar year. And so what they did here was that they looked at 872 emergent laparotomies. They excluded about 24 of them that were intraoperative deaths. And of those, only 209 of them had damage control laparotomies. They then voiced those 209 damage control laparotomies to their cohort of trauma surgeon. And what they found is that 162 of those patients truthfully were appropriate for damage control. They had a very strict criteria with which they described these patients to be as, damage control, not like, did they meet certain physiologic parameters? Did they meet certain, acute, surgical indications? And they excluded 3 of the deaths that happened within 5 days. So what they found from that cohort of 209 patients were that 44 of them were, had surgical equipoise, meaning no one could truly decide, if there was a true correct answer for these patients. And what they did for these patients is that they matched them to patients who had similar injuries, historical injuries, who then had definitive repairs, kind of historically speaking. And what they found, and their data is actually rather interesting, right? What they found was that the risk of a major abdominal complication is that if you were to preemptively close these patients definitively, at their first laparotomy, was they had a posterior probability of roughly 56%. They also identified was that these patients had a shorter ventilator-free days, shorter ICU-free days, and shorter ventilator-free days. And what they then concluded was that if you were to close these patients, right, and this is a Bayesian analysis, it's matched to retrospective patients because unfortunately there's no way to sort of prospectively say what would happen if you were to close a patient that you already did a damage control laparotomy on definitively. But that in these patients with whom surgical equipoise exists, that their definitive closure was associated with a similar probability of major abdominal complication. They were suggesting that the 50%, 56% was kind of equivalent to keeping them open versus kind of closing them at the initial operation. Again, the same group in 2018, they did a multifaceted retrospective quality improvement analysis. Okay, and here they looked at patients from 2013 to 2015, and these patients were all adjudicated. Again, patients who were appropriate for damage control laparotomy, or patients who could have safely undergone a definitive closure at the primary operation. And their primary outcomes were major abdominal complications. And what they said was that all things being equal, if a second look laparotomy was negative, meaning, in these patients that ended up getting a damage control laparotomy, and they subsequently went and had a second look laparotomy because someone was concerned and wanted to take a second look, if everything was negative, then those patients could arguably be considered, or have been considered, safe for initial closure. And what they found was that, in these patients, if they then again sort of prospectively sort of suggested that whatever complications these patients had, they had a significantly higher rate of major abdominal complications of about 56% versus kind of leaving them open. And they concluded that this was kind of a higher risk so they concluded that there was a higher risk of major abdominal complications with an open abdomen. And again, this is sort of a limited study because it's a retrospective study, and they sort of made presumptions on their outcomes, and it was a relatively small sample size. When you actually look at the breakdown of their data, they had about 1,029 emergent laparotomies. Of those, about 65% were definitive and 31% were about damage control laparotomies. Of those 321 patients, about 43 of them had intraoperative deaths. They then, did their quality improvement and sort of evaluated these patients, and really only identified 27 patients who, could have potentially been closed. And they then did, one-to-one matching, and really only found 16 pairs that they could match with historical cohorts. The things that make this interesting is that, these patients had very similar injury scoring scales, very similar injuries, very similar BMI, pre-hospital vital signs. And so based off of the complications that the patients who were definitively closed in their historical cohort, they were able to come to these sort of suppositions. And this is sort of, kind of a demonstration of, the data and how and what their complications were. But again, they sort of had the same sort of conclusion that there's about a 56% risk of major abdominal complications. But the fact that they leave the ICU earlier and they leave the hospital earlier and they have a shorter length of stay, is potentially an improved things in patients where this is sort of, a possibility. So now, if you remember, we discussed this paper from the Journal of Trauma Acute Care Surgery in 2009. We were talking about hypertonic saline. And so what makes this an extremely interesting article was that in this patient, they had a very significant protocol design of 60 patients. And they did a cohort analysis and compared it to their historical controls of 78 patients. And these were all matched to their significant inclusion criteria. And these patients all had, hypertonic saline, direct peritoneal resuscitation, and they had an extremely strict criterion with which these patients were monitored in terms of, what happens if this happens, we do this. If this happens, we do that. It was a very, very, very stringent protocol. They excluded all the patients who, had any possibility of renal disease, any possibility of any other significant medical comorbidities. Every patient was started on hypertonic saline at 3% on postoperative day 0 and were continued to do that till their definitive closure, unless they became hypernatremic or developed, any significant acidosis. And what they found is that, these patients, when you compared their data points, was that primary fascial closure was sort of improved with this protocol implementation. If you look at sort of the serum sodiums in patients who didn't have the protocol in the historical cohort and after the protocol, they demonstrated that for the most part, they're relatively equivalent. When you look at their chloride, you'll notice that there's really no significant difference, at least, based off of the graphs that or the tables that they provided us with, relatively similar across the whole point. Their serum osmolalities, were relatively similar, and their serum creatinines are relatively similar. But what they did find, and I think the takeaway of this article though, is not necessarily the utilization of hypertonic saline or the utilization of direct regular resuscitation, but it's simply that having a protocolized design where all these patients follow a standard pathway, which is a conclusion that they came to in this paper, had a fairly significant decrease in open abdomens and had an earlier primary fascial closure rate, specifically at sort of 70 hours, right? A lot of those patients were significantly closed by that point, just looking at the way their data sort of falls. And, again, this is just kind of a tabular or a graphical demonstration of the same sort of thing, is that, again, kind of looking at all these things with, all of their different metrics that they evaluate, that again, it sort of demonstrated kind of a decreased time to primary closure. And so, this this article is an interesting one. This one came out about 2 years ago. And what they wanted to do was sort of figure out what are the reasons that people keep patients, or rather surgeons decide to keep patients' abdomens open. And what they described was kind of a new classification system. Okay. This was a single center, it was a prospective study that evaluated patients with open abdomens. So what they did was that in the OR, there were these research, adjuncts who would come into the OR at the end of an operation or at the beginning of an operation and essentially ask the surgeon, are you planning to leave this patient open or not? And the surgeon would indicate what they thought based off of their initial presentation, what they thought. And generally the answer was, well, I'm not really sure, let me see what happens. Then they do the operation, and then immediately after they finished the operation, they were given a evaluation that basically they had to list out what were the reasons that they elected to keep someone open. Was it an anatomical issue? Was it a physiological issue? Was it a logistical issue? Now, if you'll notice in the table, all of the three groups have an equivalent N. And what they identified was that, if sort of left to their own devices, instead of choosing a single primary, reason, a lot of the surgeons often had multiple reasons, and they sort of allowed for that. So it's really hard to draw any clear conclusions from this specific article, but it's interesting to consider that, a lot of times it's not significantly one reason versus the other. And, the other issue is that because these patients were sort of split over all these three different groups and sort of combined together, it led to a relatively small sample size. And, the conclusion they sort of came to at the end of their research study was to basically say that, perhaps, developing this classification system and finessing it a little bit more could suggest, a better way of identifying patients, or at least classifying patients in terms of whether or not they fall to the anatomical group, the physiological group, or the logistical group, right? Because, in the patients who were in the logistical group, for example, whether that was, the patient, there was only one trauma surgeon in-house and, they had another gunshot wound they had to get to, or, they were concerned, they wanted a second look, was what they found the patients who perhaps, sort of self-explanatory, but the patients who fell in this logistical group were all closed on the second look. They were all more expeditiously closed. They tended to have less abdominal complications, right? The patients with the physiological group, what they sort of demonstrated was that no, they tended to have kind of a less expeditious closure. And the patients with the anatomic group were kind of somewhere in between. Some of them were closed expeditiously, some of them not, depending on what the anatomical reasons were. And so I think this is a very interesting proposal, and I think one that perhaps should be evaluated a little bit more carefully in terms of stratifying why we make the decisions to sort of keep patients open. And so I think this, everybody's, probably wondering at this point, well, we just reviewed kind of the physiology, kind of the indications, and, all the different adjuncts we have and all of the sort of mixed data. What does all of this really mean? And I think that there are a couple of things to consider. I think on one end, I think, there should be a constant reevaluation of the lethal triad, right? With modern day resuscitation, with how effective we are at getting blood products into patients, with how effective we are at truly managing the medical side of things, does that improved resuscitation correlate with decreased rates of open abdomens? In other words, are we really seeing patients on a regular basis who truly fit in that lethal triad? I know they exist. I've seen them. I still see them perhaps somewhat regularly, but is that more of a metric of the severity of their injury? And perhaps that is why they should qualify for an open abdomen, or rather, sorry, a damage control laparotomy. Or has our resuscitation got to a point where it's so efficient and effective that perhaps we can mitigate some of the issues that kind of portend long-term open abdomens? Another thing perhaps to consider is kind of circumventing some of these logistical reasons, right? You have a really bad trauma, you look at all the injuries, you make sure to assess all the injuries, you try to control all of the injuries. Do we tolerate a quoted 56% risk of major abdominal complication and having a definitive closure? Or do we play it safe and say, hey, this was a bad abdominal injury, and perhaps there's some surgical equipoise on whether or not to keep this patient open or closed. But do we come back for a second look, and do we look and say, hey, everything's fine, we can close them now, so that we can make sure this patient doesn't have a major abdominal complication? And then the other real thing, and I think this is a real question to sort of ask, is that there is a significant resource utilization, whether it's OR time, whether it's hospital resources, whether it's, surgeon anesthesia time, whether it's the ability to get to other patients, and even the significant physiological effects that, multiple trips with an open abdomen going to the OR does to a patient, right? Does the data truly support how significantly expanded its utility is, right? The initial data criteria had a very, very narrow scope, but if you're seeing around 36% of trauma patients who are getting an open abdomen, does the data really support utilizing it that extensively? And so, I think my final thoughts on all of this is that, I think standardization of protocol and not to make surgery algorithmic perhaps, but I think having some standardized protocol when dealing with open abdomens in terms of, how they're resuscitated. It's very specifically how they're resuscitated, whether it's using hypertonic saline or direct peritoneal resuscitation or LR, whatever, your poison of choice is for these patients, having standard timing for when they go back to the OR, having a significant protocol that is put in place that is implemented at every level. I think that could potentially improve some of these outcomes. I do think we need some more randomized controlled trials to kind of evaluate the different adjuncts that we have and sort of how to implement them and how they could potentially facilitate open abdominal closures. I think perhaps we've become a slight more liberal in our indications for damage control laparotomy and trauma patients. And if a patient needs it, then they absolutely need it. But perhaps, being a slightly more cognizant of the seeming overutilization of it in the world of trauma surgery. And then kind of, the last question is, are we going to tolerate these major abdominal complications in these patients whom perhaps surgical equipoise does exist regarding a damage control laparotomy? And so, lastly, obviously, we do this because it has saved countless of lives, right? Countless of lives have been saved by the advent of modern trauma day surgery and damage control surgery and the aggressive resuscitations that we do, and it is an extremely important tool. Perhaps what we need to do is sharpen it a little bit and kind of find ways to be more judicious and specific with it, as opposed to the seeming kind of increased utilization of it, particularly when considering the significant comorbidities that are associated with it, along with the risk it has to the patient to keep them open for a longer period of times and their subsequent comorbidities, and the eventual resource utilization that's kind of associated with it. So I wanted to thank you all for your time, and I'm happy to take any questions.
Hey, Rami,
Rami.
this is Armstrong.
Hey.
Great talk. Thank you. Great review of the literature. I just wanted to I have a few comments and then maybe a couple questions too. I do think since the Iraq and Afghanistan, the open abdomen has sort of become more prominent in use, perhaps in civilian trauma, but resuscitation has also changed, right? The
Right.
utilization of blood products has taken a huge shift back towards the past, actually. And our overall volume is probably less. Of course, the literature needs to pan out on that. I do think that there are certainly indications for leaving a belly open, impact, liver, with massive trauma, coagulopathy. But there's also, I think, you certainly will inherit patients, right? That you're like, well, why was this patient left open? And there's maybe like just a fear side of it, or rather than like a physiologic state that necessarily needed it. And I think we do see open bellies that shouldn't be open. And then when we do see open bellies in the ICU, I think there are certain things that we sometimes at WashU in particular, maybe aren't quite caught up on, maybe on the cutting edge of the literature, including feeding patients who are in continuity on an open abdomen. It's retrospective evidence, but Vanderbilt in 2007, Jose Diaz was the lead author, or the chief author on that paper rather, but showed that these patients had lower fistula rates, lower ICU stays, and decreased time to closure, not necessarily decreased morbidity. And then extubating these patients, that's sort of pushing the edge. And yeah, the evidence is small, but a lot of people used to think, well, this patient's got an open belly, they need to be intubated and heavily sedated so they don't lose domain, or pain control reasons. But an open belly is no more painful than having a closed belly necessarily. And does having these patients on the ventilator longer result in worse outcomes? And then considering the old data, a lot of people used to paralyze these patients heavily, just so that, again, due to the thought they were going to lose domain with resuscitation. And I think a lot of that was, rather than their abdominal wall stretching, was over resuscitation with crystalloid. And so getting away from paralyzing these patients unnecessarily, I think, is important. And so again, I think this evidence, if you can compare retrospective studies, you got to look at this. And then my last comment has, and I have more of a question for you, is the use of hypertonic saline in these patients. And I'm curious, within that data, was there evidence of increasing acute kidney injury or need for CRT or dialysis in those patients?
So I'm happy to show it to you, but when they actually looked at it, let me see right here. If you look at this table here, their serum creatinines were relatively equivalent across the board, at least in the patient that they had the standard protocol implementation on. In the other one, to be honest with you, I don't remember if they commented on acute kidney injuries. I think they just said that it was very effective. But the problem with this particular study was that if a patient had an acute kidney injury prior to them implementing this protocol, they did not include them in the study. So it's hard to really tell. I guess if you're 25 and have healthy kidneys and get this, then you'll probably be fine. But if you're 65 and had a bad car accident, it's hard to tell how to kind of use this data to sort of support that. But at least in this cohort that was previously healthy with no AKI kind of going into it, they identified that these patients did not have an increased risk of acute kidney injury.
I have just one more comment too, and this is more of a stylistic, and I don't think it's been studied, but leading into an operation where you're doing your take back, I'm a big fan of diuresing these patients, especially if they've gotten more of a crystalloid type of resuscitation, to the point where they're either their creatinine bumps or they're on a little bit of pressors. Because I'd rather see less edematous bowel and less edematous retroperitoneum and an abdominal wall and deal with some brief pressors or maybe some brief mild hypovolemia to get them closed than having them otherwise. And I don't think that's necessarily been studied. And I think there is some hesitancy sometimes
So
for
I
comfort
discussed
level.
2 of the studies. I discussed 2
And
of
I
the
came in a little
studies.
late, so sorry I missed that
Oh,
part.
that's okay. I talked about the East, meta-analysis that looked at diuresis and direct peritoneal resuscitation and hypertonic saline. And the 2 studies that,
Oh. Hopefully he comes back. We'll give that a sec. I think we lost him for one moment. So hopefully he's coming back on. We can finish that. I guess I'll take advantage of the break just for a moment. If there are people having trouble with CME credits, I know we've been working on getting the CME office up to date on everything. We keep submitting stuff, and so just please keep letting us know. If people have ideas for talks, please let me know. I'm still working on filling this year, so I'm definitely open for talks. And had someone change up their dates, so an earlier date opened up.
hey, sorry, I got cut out for some
Perfect.
reason. I'm sorry about that.
No worries at all. We figured you were probably coming back on.
I don't know what happened. Were there any other questions?
I know you guys were talking about diuresing ahead of time. I just want to put out there, what do we do? Do we have data on any of this at WashU?
Not from what I've seen, at least in our ICUs. It's very dependent on the care team. So
I guess my question would be, especially the way you guys as surgeons were talking, what would you like to see us do, or where do you think we could go from here and learn from this?
I am a huge believer in protocols, and not necessarily because I like algorithmic medicine, but because I think that if you have a protocol that everyone follows, that sort of simplifies some of the questions and there is less room for error. So patients won't just be left on LR at 125 an hour for 72 hours. And so my push would be to sort of kind of have the departments of anesthesia and trauma surgery kind of come together and sort of discuss where could we protocolize kind of the post-operative care in these patients in the ICU and the subsequent takebacks, instead of, some days it's on Monday, some days it's 3 days later, kind of depending on a variety of different reasons that may or may not be always in the patient's best interest. Not that we're necessarily delaying care, but sometimes emergencies arise that sort of put things off. And so I think having a standard protocol may perhaps help with some of our outcomes. Just my personal humble opinions.
No, and I think that's important to think about, because I want to make sure we get something out of these, and we look at our care and we say, can we do this better? And I see a lot of places, I know we've talked about this offline before.
Mm-hmm.
A lot of places track this stuff, and maybe this is being tracked, but we all don't know the information, and maybe this is just something that we need to be cognizant of and sharing and looking at and saying, okay, here's another open abdomen. Why? And why are we keeping this one open? What are we going to do with it? And then I completely agree with you about the protocols. I think especially as someone that goes back and forth between the ORs and ICU, it would really help to kind of have a continuity where we know what to expect in terms of the care and what we're getting into.
I think as far as the various adjuncts, I mean, I think there's some data to support them, but I don't think it's any real definitive data that's truly going to change clinical practice yet. I think there's definitely a lot of potential. Like it makes physiologic sense to diurese. It makes physiologic sense to give hypertonic saline, but I think the data is very split when you actually look at the studies that we have available, and mainly because these are actually very challenging things to truly evaluate in a randomized setting where you're dealing with patients who are on death's door. It's very challenging to kind of evaluate these things on a regular basis.
And I know Lindsay Cranker gave a talk last year on, I think it was the peritoneal
Resuscitation.
Yeah, and so I'll point people to the Whistle box on that because I know that lecture is recorded. Any other comments or questions? All right, well, I know we're right at about 6:30. So with that, thank you all, and I'll see you guys next month. I'll send out the invites shortly. I know Maggie Spruce, I think, is up. I checked my board for next time, so I'll send that out shortly. Thanks, guys.
All right, thank you.